Good afternoon, everybody. I am Dr. Reepa Agrawal, and today I'll be presenting a very interesting case. It was a bit mind-boggling because of the microbiology. Okay. We all know that we look forward to get a microbiological diagnosis for all our TB patients. But now when we have an array of microbiological tests, sometimes it becomes a bit difficult to interpret them and to really understand which test is most better for our clinical patient. So first of I would like to thank Dr. Shah madam for giving me this opportunity to present this case in this. To begin with, a 9-year-old lovely female child was referred to our TB clinic in March 2024 for further management. So she presented with complaints of swelling in the left cervical region since last 1.5 months. There was no significant history of contact with TB or any past history of TB. There was no history of fever or weight loss. Now, this child had undergone FNAC in March, which had shown necrotizing inflammation. A Genexpert from that aspirate had not detected Mycobacterium TB complex. But based on the FNAC report, as well as clinically, the child was started on first-line AKT in the first week of March. So what we have gathered till now is there is no microbiological diagnosis and the TB MGIT report was pending. Okay. We had continued the same first-line AKT for the child when the child is presented to us in April. Now, this child on examination had pallor and had left-sided multiple cervical lymph nodes in the submandibular, supraclavicular, and left posterior triangle area. This was non-tender, matted, and the largest was measuring 2 into 1.5 centimeter. Anthropometry-wise, the weight was 30.2 kgs and the height was 127 centimeter, which lies in 25th to 50th centile. The systemic examination was unremarked. Now, the investigations which we had showed a hemoglobin of 10.7, which was low for her. ESR was 70, CRP was normal, and HIV was non-reactive. Just to recap the investigation which we have till now, we knew that there was a lymph node aspirate which was showing necrotizing granulomatous inflammation. We had a lymph node aspirate TB Genexpert which had not detected MTB. The child had also undergone a GL Genexpert where MTB was not detected. TB MGIT which was awaited has subsequently turned out to be negative. This could also be due to the low sample load which we get in FNAC. A USG neck was not done at baseline. X-ray was normal. And what we did not really have any microbiological diagnosis. Now, this same girl, she followed up with us on 22nd of April with pain at the left cervical lymph node site. Now, the good thing here was that clinically there was a weight gain of 33. There was a weight gain, and the child was now weighing 33 kg. So almost 3 kg weight gain was there in the last 2 months. But on examination, she had red and tender cervical lymph node. Okay. A USG neck was ordered, which showed multiple hypoechoic lymph nodes in the left submandibular, cervical, left supraclavicular, and left posterior triangle area. Most of them showed loss of hilar reflectivity, that they were necrotic. Okay. But I would like to draw your attention towards a small ill-defined collection which was seen in the subcutaneous plane of the left posterior triangle area, which was probably the cold abscess which the child had developed. Now here we have a multidisciplinary team at Wadia Children's Hospital, and so a pediatric surgery reference was taken for excision biopsy and for further microbiological evaluation, which included Genexpert, TB MGIT, as well as pathology, that is histopath. Now, This time, luckily, we could isolate the MTB complex. It was detected. Okay, so the TB Genexpert picked up the MTB complex, although it was low. Reepa resistance was not detected. Okay, so now this is in April. Okay. Next, on histopath, what we saw was that there was the lymph node was showing effaced architecture and it was replaced by granulomas, okay, which was composed of central caseous necrosis, rimmed by epithelioid cells, lymphocytes, plasma cells, and Langerhans giant cells. Other investigations which were reflexly are LPA of tissue and the TB embedded culture, okay, as per NT. Treatment, as I mentioned, HRZE and paradoxin were continued for the child. Now, this is a very interesting slide, and this is the crux of today's talk, how to decode this microbiological mystery. Now, on the left side of your screen, you are seeing the line probe assay, the first line. Okay, the first line LPA, which we got on 12th June, showed us rifampicin resistance inferred. Okay, and the TB Genexpert had showed Reepa resistance was not detected. Just keep that. And INH mutations, that is CATG and INH-A, there was no resistance detected. Okay. And the second line LPA mutation, the resistance mutations were detected for levoflox as well as moxiflox. Okay. And the second line injectables, there was no resistance detected. Now, let us go to the right-hand side. At the bottom, what we are seeing is that TB-MZ culture came positive at around 8th of July, and then a DST was done. Now, this is phenotypic DST. Okay, LPA is a genotypic DST. Here, what we found that there was resistance to pyrazinamide, but moxifloxacin, low as well as high, was susceptible, and linezolid was also susceptible. Okay, so there is a discrepancy in the fluoroquinolones as well. In LPA, it is showing resistance detected, whereas in the phenotypic DST, it is showing it is susceptible. Okay, so how to interpret this? So how do we interpret these discordant reports? Is it Reepa resistant or is it Reepa sensitive? Okay, we know that here. Why are we asking this question? Because we want to know whether it is MDR or not. Okay. Our first and LPA has shown Reepa resistance inferred. Genexpert has shown Reepa resistance not detected. So, should rifampicin be used or not? And why? So, here, what is most important to know is that Genexpert is a better modality when we are talking about whether it can detect Reepa resistance or not as compared to your LPAs, because LPA is an open system and there can be contamination, whereas your Genexpert is a closed system. Okay, so we will go with our Genexpert. Okay, so should we use rifampicin or not? Yes, we will use rifampicin. Now, next question was, is it fluoroquinolone sensitive or not? Although we are giving first line, but here we have got a second line NPA, which is showing that fluoroquinolone was resistant. But we have a DST, phenotypic DST report, which shows it is susceptible. So we would again go with the DST, phenotypic DST report, which is a gold standard. Okay, but mind you, the PZA resistance on phenotypic DST is not very reliable. Okay, and it is not reproducible. Okay, that is important. And not all PZA resistance is M-Bovis strain. It can be false positive also. Okay, what is important to note here is patient was responding clinically to our first line drugs. Okay. So on follow-up, what we are seeing here is that multiple lymph nodes which were hypoechoic or necrotic have resolved, but there was only residual disease seen in the left neck node at 5A level, okay, which has also decreased in size. Okay. So of course there was treatment which was working, okay, and it was the first line. And here the duration of treatment will not just be 6 months, it will be based clinically. Okay, till the necrosis resolves. Okay, that is important. Now the sensitivity and specificity of all these tests, okay, when we see for extrapulmonary samples. Genexpert sensitivity is 50%, specificity is 97%. Genexpert ultra sensitivity is 69, around 69%. Specificity is less, it is just 58.6%. LPA sensitivity is 80%, whereas specificity is only 11%. Okay, so it really drops. MJIT sensitivity is 95%, specificity is 99%. Okay. And phenotypic DST for PZA lacks reliability and reproducibility due to technical reasons, and hence there are a lot of high false positive rates. Okay, so you have to take that report with very carefully. Okay, and there is no WHO endorsed phenotypic DST. Okay, so you have to be very mindful. And unfortunately, the NTEP doesn't provide with rifampicin DST. Okay. So hence, what we conclude is all microbiology is going to support us. It is going to help in formulating a regimen, but of course, clinical correlation is a key, and we must know how to interpret the microbiological results. Okay, and I hope after listening to this fascinating case, we are able to get closer to the understanding of these microbiological results. Okay, now I would like to ask Shah madam take over the discussion.
So as you can see in this patient, you have a Genexpert which says rifampicin sensitive. You have an LPA report which says rifampicin resistance but no INH resistance. And the second line LPA shows resistance to quinolones, but you also have a simultaneously DST which shows that quinolones are susceptible. So you have this patient where you don't know how to interpret these reports. You have three different reports. You have something where you have rifampicin resistance not seen. In Genexpert, you have rifampicin resistance on LPA, quinolone resistance on LPA, quinolone sensitive on DST. So the question is whether you should give this child first line TB treatment or second line TB treatment. In this patient, we continued first line. And I'll tell you the reason why we did that. And you know from the results that he did extremely well on the first line. Now, if you look at various literature, it always says that phenotypic DST is the gold standard. Yes, you do have whole exome sequencing and pyrosequencing, which may be in the future the gold standard. But right now, phenotypic gold standard is the gold standard. Now, what would be the cause of discordant tests? Sometimes what happens is when you take a sample and you culture it and then you subculture it, then the slow growing resistant population, you will lose them and you may get a false susceptible report. Now in our patient, the Genexpert was the one that showed susceptible. So obviously we've not cultured or subcultured it. We've just taken a sample, put it into the cartridge and it shows resistance. It shows susceptible. So unlikely that this was subculturing and we lost the resistant population. That's not possible in our patient. Then there's something called as heteroresistance. I'll come to that later, what it means. Sometimes when you have open system PCRs, which your LPA is an open system PCR, you may get cross-contamination in the lab. There have been case reports of the bug being transmitted from the PPE kit that the technician is wearing onto the test and giving a resistance report. Or you could have a previous sample which has fallen on the table or on the floor and that gets mixed with this sample and that causes a cross-contamination and you may get a false positive, susceptible or false resistance in the report. Then you could also have a patient harboring mixed infection. So he may be infected with both the bugs, a sensitive bug as well as a resistance bug, and you may get different reports. And sometimes MIC of these isolates are very closer to the critical concentration and that can give you a false resistance report. Now, what is heteroresistance? Heteroresistance is something in which you have given antibiotic for a particular bug. That bug is trying to mutate and become resistant so that it can overcome that antibiotic. And when you do the test again on that sample, you find that there is a resistance, but these are resistance that are unstable. And usually when you remove the antibiotic, they again become susceptible. So it's not a permanent resistance that you're seeing, but it's over the antibiotic pressure that you may see heteroresistance. Now in our patient, we had this patient on first line TB treatment for almost a month before we did a test again. And that time Genexpert is sensitive, but LPA is showing resistance. So probably because of the pressure of the first line TB treatment, there may have been these unstable mutations, and that may have been picked up by the LPA. So one possibility in our patient is a heteroresistance in this case. Now remember, when we talk about rifampicin resistance, we assume that 85% of your rifampicin resistance also have resistance to INH, and that's why we say RR on Genexpert means MDR-TB. So in our patient, again, you see that his LPA showed rifampicin resistance, but it did not show INH resistance. So that did not go hand in hand with MDR-TB in this patient. So if you have rifampicin resistance, always look at INH resistance and then conclude whether this is MD or not. Now LPA results, we do this GenoType MTBDRplus test, German kit. And they look at various mutations. You look at RPO mutation, which confers rifampicin resistance. You look at CATG and INHA mutation, which looks at resistance to INH. You look at RRS for kanamycin amic acid resistance. You look at TLYA for capreomycin resistance. And gyrase A and B for moxifloxacin and ofloxacin resistance. The problem with the Genexpert is that the rifampicin resistance is picked up only if you actually look at binding with the probe. So if that bug binds with the probe, then you call it as rifampicin sensitive. And if it doesn't bind with the probe, then it is assumed that it is resistance and it is labeled as rifampicin resistance. So sometimes in Genexpert you could have a report which says trace, or it says very low load. So if you have a very low yield of Mycobacterium tuberculosis, then it may not bind with the rifampicin probe, and falsely you may get it as rifampicin resistance. So to overcome that problem, the Genexpert Ultra was developed. What it does, it's you have these specific mutations associated with MDR in the DNA, which is located on a specific region known as the rifampicin resistance determining region of the RPO. And because these additional mutations are present in the ultra, not mutations, but these copies are inserted into the ultra, you get a better sensitivity. Now you look at the LPA report. It's an open system. You have to extract the DNA, then you have to amplify, hybridization is done, and then evaluation or interpretation. So there's a lot of chances that there'll be cross-contamination that will occur. And usually in the program that we are doing, we don't do LPA straightforward, we are doing it on a culture. So already there are subcultures of these organisms. As I said, ultra, in the classic, we only target the RPO, but there are these multi-copy insertion sequences, which increases its sensitivity to detect even in possibacillary disease. And as I told you, the classical Xpert looks on the absence of probe binding to detect RR. So if you have a very low yield, you may falsely get RR. So ultra is better to detect resistance in the presence of mixed infection, heteroresistance, and ambiguous mutations. And these are the references which I would like you all to go through it, excellent papers, and which really help us to determine how to interpret these reports. Thank you very much.